Epigastric can also mimic a myocardial infarction, especially an inferior wall. Then it may also have pericarditis. It may also represent esophagitis, gastritis, peptic ulcer. Food aggravates the pain, then it is gastric ulcer. And if intake of food relieves the pain, then it is duodenal ulcer. So these are certain tips and tricks. A peritonitis patient, the patient will usually lie motionless on the bed. So patient will be fine, although patient will have more like a dull aching pain. But if the patient is having a renal colic pain, then he will always be restless. He or she will always keep on moving from side to side, trying to find a comfortable position. Remember one thing, that if there is non-specific pain or any location pain, then it can also present like herpes zoster, muscle strain, or hernia.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So it's great again to be back at Medflix, and I would like to start with our topic for today, that is approach to abdominal pain. So as we all know, abdominal pain is one of the most common complaints that we see on day-to-day basis, be it on OPD or be it on IPD. And yet we are still in a diagnostic dilemma as to what to do. Many times what happens is when we are in the OPD about 9 to 5, and then 5 o'clock when we are about to leave, just then a patient walks in with complaint of abdominal pain. And then you palpate and then you see and you ask the history. And then you are so much in confusion that whether to go home, whether to ask them to come tomorrow, or whether to admit, whether to check or evaluate whether it will be an urgency or not. We are still always in confusion about it. So this probably will help you simplify on how we can approach an abdominal pain case depending upon various parameters, and then decide on whether to go for investigating it or not. So that is the highlight for today's topic. So first and foremost, to start with, we need to think as to what does abdominal pain comprise of. So an acute abdominal pain, it can represent a spectrum of conditions from benign and self-limiting disease to surgical emergencies. Evaluating abdominal pain, it requires an approach that relies on the likelihood of the disease, patient history, physical examination, laboratory tests, and imaging studies. The location of pain is a useful starting point and will guide further evaluation. So just one thing that you need to remember, that abdominal pain, since it is the most common complaint that we see in the OPD, it is still very challenging to diagnose. Not only that, if you look at the statistics, it says that it is the presenting complaint in nearly 1.5% of the office-based visits, 5% of the emergency department visits, and more than 10% in the emergency department setting, especially on weekends. So a thorough and a very logical approach can help diagnose abdominal pain in the most appropriate way. So this is the selected differential diagnosis chart, which includes characterizing abdominal pain on the basis of the location. So if you look at the right upper quadrant, it may involve biliary causes like cholecystitis, cholelithiasis, cholangitis, colonic causes like colitis, diverticulitis, hepatic such as abscess, hepatitis, and mass, pulmonary causes such as pneumonia or embolus, renal causes like nephrolithiasis and pyelonephritis. Epigastric may involve cholecystitis, cholelithiasis, cholangitis. Epigastric can also mimic a myocardial infarction, especially an inferior wall. Then it may also have pericarditis. It may also represent esophagitis, gastritis, peptic ulcer, pancreatic mass, pancreatitis, then vascular causes like aortic dissection and mesenteric ischemia. Now I'll tell you about mesenteric ischemia. This is one of the most underdiagnosed disease when it comes to any abdominal pain case. Just remember one thing, that any elderly patient with multiple comorbidities with vascular risk factors like diabetes, hypertension, ischemic heart disease, if the patient presents with abdominal pain, then mesenteric ischemia should be there in your differential diagnosis. Then coming to the left upper quadrant, which may present like angina, myocardial infarction, pericarditis, again esophagitis, gastritis, peptic ulcer, pancreatic mass, pancreatitis, then nephrolithiasis, pyelonephritis, aortic dissection, and again mesenteric ischemia. Periumbilical area, usually an early appendicitis where the pain starts in the periumbilical area and then goes into the right iliac fossa. Then gastric causes like esophagitis, gastritis, peptic ulcer, small bowel mass or obstruction. Vascular causes like aortic dissection or mesenteric ischemia. Then coming to the right lower quadrant, which may include colonic causes like appendicitis, colitis, diverticulitis, IBD and IBS. Gynecological causes, ectopic pregnancy, fibroid, ovarian mass, torsion, pelvic inflammatory disease. Then again nephrolithiasis and pyelonephritis. Suprapubic pain, it can present as appendicitis, colitis, diverticulitis, IBD or IBS. Gynecological causes like ectopic pregnancy, fibroids, ovarian mass, torsion or PID. Renal causes like cystitis, nephrolithiasis and pyelonephritis. Left lower quadrant can present like colitis, diverticulitis, IBD or IBS and other gynecological causes. Then renal causes like nephrolithiasis and pyelonephritis. And remember one thing, that if there is non-specific pain or any location pain, then it can also present like herpes zoster, muscle strain or hernia, and other causes like bowel obstruction, mesenteric ischemia, peritonitis, narcotic withdrawal, sickle cell crisis, porphyria, IBD, and heavy metal poisoning. So these are as per the location of the abdominal pain that we need to characterize the differential diagnosis. Now, apart from the location, there are more other factors. Like, for example, if you look at the pain, you need to check for the location, as I mentioned, then radiation of the pain, the movement, aggravating and relieving factors. Associated symptoms may include fever, protracted vomiting, syncope or pre-syncope, evidence of GI blood loss, use of NSAIDs, constipation or diarrhea, and other systems involvement. Now, for example, I'll tell you, if you look at the appendicitis pain, as I said, it begins in the periumbilical area and it goes into the right iliac fossa. Then if you look at a cholecystitis pain, it classically refers to the right tip of the shoulder. Then if you look at peptic ulcer, depending upon whether it is gastric ulcer or duodenal ulcer, there may be a character of pain where food aggravates the pain, then it is gastric ulcer. And if intake of food relieves the pain, then it is duodenal ulcer. So these are certain tips and tricks that can help narrow down our differential diagnosis of abdominal pain. Apart from this, there are certain aggravating and relieving factors. So if you look at a peritonitis patient, the patient will usually lie motionless on the bed. So patient will be fine, although patient will have more like a dull aching pain. But if the patient is having a renal colic pain, then he will always be restless. He or she will always keep on moving from side to side, trying to find a comfortable position. So unable to find a comfortable position can indicate a renal colic pain. Then if you look at a biliary colic, intake of fatty food will worsen the biliary colic. As I mentioned, in duodenal ulcer, the pain improves with eating, and in gastric ulcer and mesenteric ischemia, the pain worsens with eating. So these are the basic history parameters that we need to monitor. Now, if you look at the examination. So in examination, patients with peritonitis tend to lie very still, whereas renal colic seems unable to stay still. Then fever will suggest an infection. However, its absence does not rule out it, because patients who are older or immunocompromised may not necessarily start or present with fever. Yet infection should always be at the back of our mind. Tachycardia and orthostatic hypotension will suggest hypovolemia. The location of pain guides the remainder of the physical examination, and the physician should pay close attention to the cardiac and lung examination in patients with upper abdominal pain, because they could suggest pneumonia or cardiac ischemia. I'll give you an example. Few days back, there was one patient who came with complaint of just abdominal pain, and the patient was nearly about 65-year-old, and the patient was having a dull aching abdominal pain with little bit of nausea and 1 to 2 episodes of vomiting. The patient is a known case of diabetes, hypertension, and I think patient had psoriasis also. And then afterwards, the patient had this symptom onset since about 2 weeks, and he took multiple medications, took painkillers, yet the pain was not subsiding. So when they did an ultrasound scan, then the ultrasound scan also showed nothing and did not show anything significant, no inflammatory pathologies. And if you look at the blood counts, everything was normal. So what do you think? What could be the differential diagnosis in such a case? Can anybody who has any idea, please put in the chat box. So an elderly person with an abdominal pain, known case of diabetes, hypertension, and also psoriasis, and patient was having abdominal pain since about 2 weeks, associated with nausea, associated with vomiting, and no history of fever. And along with that, patient took a lot of painkillers. On ultrasound, nothing was seen, and the blood infective total count, everything was normal. So, what do you think could be the cause in such a case? Anybody who can think of differential diagnosis related to this? Related to liver case? Okay, possible. But if it was that, then probably an ultrasound should have shown it, or the liver function should have shown it. Cardiac ischemia or pneumonia to be suspected, like lower lobe pneumonia. Okay, so patient did not have any crepitations, patient did not have any cough, and the patient did not have any kind of fever. Then ketosis or MI. Okay, that's a good one, a good differential diagnosis. But patient's sugar was about 180 and urine acetone was also negative. Then mesenteric ischemia. Okay, that is a possibility. Patient was not in any atrial fibrillation. Patient was not having a very severe pain, but just a mild dull aching pain. Pancreatitis. Okay, amylase lipase levels were normal. Then anything else? Peptic ulcer disease. Okay, but there was no variation with food. Diabetic gastropathy. Again, a good differential, but patient was having this only since 2 weeks and there was no similar episodes in the past. Cardiac cause. Okay, tropi was normal, ECG was normal, echo was normal. Peritonitis. Okay, but there was no other infective cause and ultrasound showed no signs of peritonitis. Inferior wall MI. Again, ECG was completely normal. Okay, so I will give you a clue. So DKA, as I said, there was no urine acetone was negative. Okay, I will give you a clue. I mentioned the entire scenario in my history. Okay, TCA or SSRI or functional pain syndrome. Not really. Patient was not taking any of those medications. So, okay. So when I said the entire history, nobody asked me that what he is taking for psoriasis. So the point was the patient had been taking steroids for psoriasis, and since last 2 weeks, the patient did not take steroids. So what happened? The patient suddenly stopped oral steroids. The patient started developing adrenocortical insufficiency, and that was the cause for abdominal pain and vomiting. So what I'm trying to tell you is that most of the times our diagnosis lies in the history itself. Okay, so in such a case, how would you have diagnosed it? Probably you could have just checked an electrolytes level. Okay, an electrolytes level would have showed something like an hyponatremia and then hyperkalemia. I did not mention it to you, but you could have asked me. So if it was hyponatremia with hyperkalemia, then probably that could have been a cause stating adrenocortical insufficiency. You can look for ABG, you can look for the presence of acidosis and things like that. So this is the way where history and examination plays a very important role. Okay, now coming to this important sign. This is called as Carnet's sign. Okay, so what is Carnet's sign? Is that when you should ask the patient to lie supine and ask the patient to lift his head on his own. So by lifting the head, the abdominal wall starts becoming tensed. Okay, so when the abdominal wall becomes tense and the patient develops pain, that is a characteristic sign that there is some kind of somatic pain. So it may include something like hernias or some nerve entrapment syndrome or some irritation of intercostal nerve roots, or there may be a disc herniation, or there may be a myofascial pain and things like that. But if the Carnet's sign is negative, then the cause is something intra-abdominal, something like a visceral cause. Okay, so basically this sign is most important to identify whether it is an intra-abdominal pain or whether it is something related to a somatic pain. Okay, so that is why I have mentioned this sign in particular. Then this sign, we all already know about it. That is the Murphy sign, where if we palpate deep into the gallbladder, the patient develops a catch in breath. So abrupt halt in inspiration during palpation indicates Murphy's sign, which is classically seen in cholecystitis. So one important thing is that in abdominal examination, the entire history and examination is incomplete if you don't go for a digital rectal examination and a pelvic or vaginal examination. So what happens is most of the times we have so much of rush in the OPD, or we want to finish off the patient fast that we do not check this. But it gives important clues that can help us diagnose or narrow down our differential diagnosis in abdominal pain. So a rectal examination may reveal fecal impaction, a palpable mass, or an occult blood in the stool. Tenderness and fullness on the right side of the rectum can suggest a retrocecal appendix. A pelvic examination may reveal vaginal discharge, which can indicate vaginitis. The presence of cervical motion tenderness and peritoneal signs increase the likelihood of ectopic pregnancy or other gynecological complications such as salpingitis or tubo-ovarian abscess. So once we complete the history, once we complete the entire examination, then we decide on what investigation should we do. The basic problem that we have is that we think that whether to go for an ultrasound or whether to go for a CT scan. Of course, CT is more expensive than an ultrasound. So we may think that, okay, let's save some money for the patient and we think of going for an ultrasound. But sometimes what happens is that with an ultrasound, the visualization is so poor that you may later need a CT scan. So that increases the financial burden on the patient, and also it increases the time limit towards diagnosis. So, that increases the patient irritation, and, a lot of such problems come up. So the best way to think about is to decide where the quadrant of pain is. Let's say you have a right upper quadrant pain, then to visualize the liver, visualize the gallbladder, and ultrasound is always better. If you look at the left upper quadrant pain, then it is a non-specific pain. Then you need to go for a CT scan where you can think about stones, renal stones. You can think about UTI, pyelonephritis, even if you need to check for splenomegaly, then coming to, or splenic abscess, then coming to a right lower quadrant. If you see the right lower quadrant, it involves more of the colonic structures. So when you want to diagnose something related to the colonic structures, always CT is better. And that too with the contrast media, of course, after checking the renal function test and the feasibility. Then coming to the left lower quadrant, where you need to look for diverticulitis in particular, again, that involves a CT scan with oral and IV contrast media. And if you're suspecting a suprapubic pain, then an ultrasound would be the crucial one. So if you look at the imaging modalities that we have, and if you are fairly sure about which organ is involved at least, then you can think which imaging will help in which quadrant. So that is something which you need to remember. Okay, next question. Can anybody tell me that what is significant in this X-ray and what could be the pathological finding? This is something which we commonly see. So I'm sure everybody would know this. This is a spotter. Anybody who can tell me what you can see in this particular X-ray? I will not give you a symptom. I will not give you a history because this is it's a spotter diagnosis. So an X-ray of the chest. Excellent, Dr. Narendra. That's right. Pneumoperitoneum is not fully correct, but yes, gas under diaphragm. Gas under diaphragm, which definitely indicates a perforation of the GI tract. And if it's a pneumomediastinum, then you can see there is a continuous diaphragm sign. Okay, both the diaphragms will look like merged together. So that is more like a pneumomediastinum. Okay, that's right. So GI perforation is the answer. Okay, now anybody who can tell me on this? This is also very easy. Everybody would know this. So what do you think this is? This is an X-ray abdomen erect showing multiple. That's right. Very good, Dr. Nitin. So it is showing obstruction, that is multiple air fluid levels are seen. So this is very classical in intestinal obstruction. So these are just two images that I put to make it a little more interesting, and something which we commonly miss out, especially the air under diaphragm. So be careful when you take a chest X-ray. Do not just look at the intercostal spaces. Do not just look at the ground glass opacities or bronchovascular markings. It's important to look just below the diaphragm too. Now I will divide the abdomen into 4 quadrants. Okay, that is the upper right, upper left, right lower, and left lower. And then we'll decide how to approach each case. Now, if you look at this, First and foremost, we will go towards evaluation of abdominal pain in a special population. So if you have a female patient of, let's say, a childbearing age, then first thing you will do is perform a pregnancy test. So if you have a pregnancy test and if you have an abdominal pain in a female patient of childbearing age, it's important you take the menstrual history. Now, if the menstrual history is correct and patient has got her periods, then you won't go for a pregnancy test. What I meant is that history is important. And once the patient has a history of missed periods or irregular periods and the periods this month has not come, then you can think of performing a pregnancy test. If it is positive, go ahead to perform a transvaginal ultrasound to evaluate for ectopic pregnancy or other complications. Now, let's say the pregnancy test is negative, then ruling out a genitourinary cause of pain is very, very important. So you ask for vaginal discharge, you ask for burning micturition, you ask for foul smelling discharge or genital area pain and things like that. Okay, now let's say you have a patient who is older or very frail. Then you will see whether there are low risk categories or it belongs to a high risk category. If you have stable vital signs with limited comorbidities, then you can think of considering urinary tract infection or diverticulitis, which are common misdiagnoses, and general workup for abdominal pain. Most often what happens is an elderly patient presents with just abdominal pain. He may not have urinary complaints, he may not have fever, he may not even have vomiting, but still he may have abdominal pain and you may wonder what's the cause. So it's important to test for a urine routine minimal, which is hardly 100-150 rupees, and that can help you guide towards your diagnosis. If you have a high-risk patient who is having unstable vital signs with significant comorbidities, you need to consider sepsis, perforated viscous, or ischemic bowel, and hence you will go for performing computed tomography and consider hospitalization. So these are some missed things which are commonly seen in evaluation of abdominal pain in special population. Now let's come to some list of missed differential diagnosis. So if you look at this slide, a woman of reproductive age, the commonly missed diagnoses are ovarian cysts, uterine fibroids, tubo-ovarian abscess, endometriosis, and ectopic pregnancy. And in older population, you may have an occult UTI, perforated viscous, and an ischemic bowel disease. So most often what happens is when you have something like a 25-year-old, 30-year-old female who comes with an abdominal pain, and then you go for a scan and you see an ovarian cyst. Every ovarian cyst is not painful. That is something you need to remember. The ovarian cyst should show internal septations. The ovarian cyst should show internal echos. And then if you rule out all of the possible causes and then you find that these findings are there in an ovarian cyst, then only that is infective. Then only you need to treat it. Just a simple plain ovarian cyst is not a diagnosis for cause for abdominal pain. Another thing that you need to remember is that presence of one ovarian cyst, do not write it as PCOD. Okay, that is very, very important. In PCOD, there is a criteria, okay, that is called as the Rotterdam criteria. So as per the Rotterdam criteria, to diagnose PCOD, the first thing you need to have is irregular cycles or anovulation. Second, you need to have signs of hyperandrogenism like hirsutism. And third, you need to have presence of cysts in the ovary, but that should be at least more than 10 cysts. Okay, so that also with a particular dimension. So these are certain important things that you need to remember when you deal with gynecological cases. Now coming to the next one, that is approaching a right upper quadrant abdominal pain. So if you have a right upper quadrant abdominal pain, categorize it into pulmonary symptoms, urinary symptoms, or colic symptoms. If you are suspecting pulmonary symptoms, consider pulmonary embolus or pneumonia. Urinary symptoms, consider UTI or nephrolithiasis. And colic, then consider hepatobiliary cause or a nephrolithiasis. Proceed towards a physical examination. In case of pulmonary symptoms, you will find tachypnea, hypoxia, or other pulmonary findings, and then you will proceed towards chest radiography. If it's non-diagnostic, you can go for an HRCT or a D-dimer to evaluate for pulmonary embolism. Now, if suppose on examination you find something like urinary symptoms, then you will look for costovertebral or suprapubic tenderness, go for a urine analysis. If there is presence of pyuria, consider a UTI or pyelonephritis. If presence of hematuria, then consider nephrolithiasis and then proceed for a CT scan. If you're suspecting a colic pain, then you need to consider hepatobiliary cause or a nephrolithiasis. Go for a physical examination, go for an ultrasound. If it's still undiagnostic, then go for a CT scan and check for the possibility of renal stone. Now let's go to the next one. Approach to left upper quadrant abdominal pain. Now this is interesting because what we always think in our mind is left upper quadrant pain is the presence of spleen, some amount of stomach, some amount of left lower lobe of the lung, and then we get confused how to proceed with it. So this is how you need to categorize, where you will check for there is history of GI symptoms, urinary symptoms, respiratory symptoms, or cardiac symptoms. And accordingly, you will do an X-ray. You will go for lab evaluation where CBC, urine analysis, amylase, and an ECG. Now you categorize it further. If you see an abdominal ECG, investigate for cardiac problems. If you see GI symptoms, investigate for peptic ulcer or other stomach and colon problems. Proceed for endoscopy or colonoscopy if indicated. Then if you see an abnormal urinary symptoms, go for an ultrasound of kidney or urinary tract. If you see an increased amylase, go for ultrasound of liver, gallbladder, and if necessary, you can evaluate the pancreas through CT. If you have a normal urinary tract, normal urinary analysis, and there are no urinary or GI symptoms, then look for the spleen or possibility of spleen involvement. And if there is abnormal chest X-ray or respiratory symptoms, think of pneumonia or other respiratory symptom problems. So this is how you need to narrow down your differential diagnosis depending upon the baseline investigation and depending upon the baseline history. So what usually happens is that in cases of any abdominal pain, most often the patient may not present to us on a first hand. He may have taken multiple treatments. He may have seen a local clinic. He might have prescribed a steroid or something he might have given. So the problem is that identifying through just physical examination becomes very difficult. So rely on history and rely on examination and rely on the basic lab investigations also. Now moving ahead, approach to right lower quadrant abdominal pain. This is something which we never miss because if we see a tenderness, the first thing we think is appendicitis. So that is something which is important to rule out. But of course, there are other possibilities too. So first thing, if you think that the pain is radiating from periumbilical area to the right lower quadrant, consider it to be peritonitis or appendicitis and go for a CT with contrast. Now, if you see that the pain is not very characteristic, that is from periumbilical to right lower quadrant, then you need to assess for the psoas muscle, assess for the rigidity, assess for the bound tenderness, guarding rigidity, or pain on the right side of the rectum. If any of these show positive findings, go for a CT scan. If negative, perform a urine, colon, or pelvic examination. So these are few things that you need to remember. So in case of psoas muscle abscess or anything, you may have loin pain. You may also have the Carnot sign, which is positive. Okay, so these are few things that you need to remember. Now moving on to the next one, that is approach to the left lower quadrant pain. So in case of left lower quadrant pain, if the patient presents with a history of fever or diverticular disease, then you need to consider for a CT scan with contrast or empirical treatment of diverticulitis. If not, then assess for abdominal distension, tenderness, and rectal bleeding. If all of these are positive, again go for CT. If negative, go for a urine or gynecological evaluation. Now coming to the generalized abdominal tenderness. So if you see a generalized abdominal tenderness with generalized abdominal guarding, then evaluate. You have to evaluate for chest X-ray, complete blood count, urine analysis, renal function test, electrolytes, blood sugar, amylase, ABG, and consider an ECG. And if it is an emergency, consult the surgeon, or you can divert it to a surgeon. Now, if you have a generalized abdominal tenderness without guarding, plus minus increased bowel sounds or plus minus abdominal distension, then you auscultate and check for any bruit. Okay, so you can auscultate the abdomen in the lateral to the umbilical area, especially in the right upper quadrant. If you just move few centimeters away from the umbilicus, you can auscultate for a renal bruit or any kind of aortic pulsation you can see. If none of these are present, you don't find any signs of aortic aneurysm, then you can go for an upright supine abdominal X-ray, chest X-ray. You can go for a CBC, RFT, electrolytes, blood sugar, amylase, and ABG analysis. Also consider an ECG. If you don't find any definitive diagnosis, then there's no option. You have to go for CT abdomen with contrast. Always remember, if you're not able to localize, not able to differentiate, do not panic and do not blame yourself that you're weak in medicine. Just go for a CT. It's important to, find any missed cause rather than saying everything is okay, you can go home. So it's very important that you realize that it's not, we are not magicians where we can just detect everything like the old age surgeons or physicians who were expert in all these things. Even when we are new generation doctors, there are possibilities that we may miss something. So it is very important that we realize it, and we should make use of the investigations also that is available to us. In olden days, a doctor who identifies through physical signs was regarded as a perfect doctor. Today, we have so many investigations available with us, and an excellent doctor is the one who guides the patient towards doing the correct investigation necessary for diagnosis. So that is something which we need to realize. Okay. Then, if you have an air fluid level, then go for treatment of obstruction. If you see a pulsatile mass or any suspicion to aortic aneurysm, go for an abdominal CT with contrast. So finally, I just want to summarize. Obtain a detailed history, that is very important. Then go for a careful physical examination. Consider the patient circumstances like history of diabetes, immunocompromised host, age, previous abdominal surgery. Then work up thoroughly and thoughtfully. Then frequent evaluation of progression. So these are all the common things that we need to remember when we approach a case of abdominal pain. Thank you.
Thank you for a wonderful session. We do have a lot of questions coming in from our doctors, and we'll be getting into that. So one of the earlier questions that we had, so Dr. Sagrin wants to know how to deal with pediatric cases.
Okay, so this is something which is not my expertise, so it's difficult to comment. But there are few things that we need to remember. There are common differentials in pediatric cases like duodenal atresia, jejunal atresia, hypertrophic pyloric stenosis, and things like that. So keep these differentials in your mind and approach it in the same way as per localization of which area the pain belongs to. Okay, and then accordingly we can decide as to how to approach each case. But remember one thing, that the differential diagnosis in pediatric cases might be different, but the approach will follow the same pattern. That is the onset of pain, duration, progression, aggravating and relieving factors, location of the pain, radiation of the pain, and things like that.
Right. So next question from Dr. Kulkarni. What is intercostal tenderness?
So intercostal tenderness is basically the space between the ribs. Okay, so whenever we palpate the intercostal area, if you find significant pain, then that indicates that there may be a chest pathology. It may include something like empyema. It may include something like even severe bronchiectasis can cause the same. If you have a tuberculous lesion, then that can also cause. So there are many reasons for it. Apart from that, there may be also some particular costochondritis, which may lead to intercostal tenderness. Sometimes what happens if you have a costochondritis, how many ever anti-inflammatory you give, it may not subside. Finally, when you take a CT, when you take some biopsy sample, you may see that it is a tubercular costochondritis. So these kind of variations also do happen. So these are some differentials you need to keep in your mind in case you're not able to find the cause.
So taking the next question from Dr. Ravindra, how to differentiate guarding from abdominal pain in DO performance clinically?
Okay, so the main thing is that whenever we approach an abdominal pain, go for a superficial and a deep palpation. If you go for a superficial palpation and then you see that what is guarding basically? Guarding means that if there is any abdominal pathology, the omentum surrounds that pathology and tries to guard it from an external force trying to apply any infection or any source of pain. So if you feel any kind of guarding in the epigastric area, the patient will cry of significant pain and you will feel some kind of a resistance. Okay, so that kind of resistance is one which can help you detect guarding. And not only that, you have to correlate with the history. If you have a duodenal ulcer, then you need to ask how the pain is with the intake of food, and things like that. So correlate with the history, you will be able to diagnose it clinically.
So next question is from Dr. Maheshwari. Diseases which can present with and without pain.
Okay, I didn't understand that question. So diseases which can present with and without pain. You mean abdominal diseases? So then if you're talking about abdominal diseases, then inflammatory ones will usually present with pain. Ischemic ones will usually present with pain. But without pain, the pathology can be related to other symptoms, maybe nausea, vomiting, maybe diarrhea. I'll give you an example. Suppose, let's say, patient is not having any abdominal pain. Patient is just having nausea and patient is having loose stool. Let's say since about 3 months. Okay, and the loose stool is the only thing which is pathological. And on evaluation, what we found is that the loose stool was large volume and it was floating, and it contained food particles also. So this can direct you towards something like pancreatic exocrine insufficiency or chronic pancreatitis. So it may not necessarily present with abdominal pain. It can present just with diarrhea and steatorrhea and a malabsorptive case. So this is one example. Every disease can present non-specifically. So it is important not to know the rare causes, but it is important to know the rare presentation of the common causes.
So there's another question from Dr. Kulkarni. What type of abdominal pain presents in ovarian cancer case?
So the ovarian cancer case, it depends upon whether how the cancer is, like whether it has spread already or whether it is still localized. Sometimes if it is just an ovarian cancer, it may not even present like an abdominal pain. It may present only with constitutional symptoms. Okay, and some amount of bleeding maybe. Okay, so if there is an ovarian cancer case, it may present with diffuse abdominal pain, and diffuse may not be very tender, very dull aching pain and chronic pain. So that is a character of an ovarian cancer case. Then most important, you need to evaluate for lymph nodes. If you see inguinal lymph nodes, you see umbilical lymph nodes, mesenteric lymph nodes, then you can think of a particular malignancy.
Next question from Dr. Patel. What are the non-surgical causes of acute abdomen and how to approach?
Okay, so if you have an acute abdomen, the most important thing is if you have ruled out any surgical cause, the basic lab parameters can help you diagnose medical causes like diabetic ketoacidosis, acute adrenocortical insufficiency, euglycemic ketoacidosis, and things like that. So if you do the basic lab parameters like complete blood count, if you look at the liver function, if you look at the renal function, if you look at the electrolytes, random blood sugar, urine acetone, and if you also take the drug-induced causes, then mostly you can get all the medical causes which are necessary to diagnose an acute abdomen.
So next question is from Dr. Josephine. Is mesenteric lymphadenitis with abdominal pain or fever, how far is it important? Because sometimes the radiologist gives us few mesenteric lymphadenitis.
Yeah, this is a very, very, very interesting question, and something which is very important that we all should know. Mesenteric lymphadenopathy is just a radiologist diagnosis. Okay, so it is important that we correlate with the symptoms. Suppose, let's say, the patient comes with long-standing fever. Okay, patient comes with just a diffuse abdominal pain or maybe no abdominal pain. And then we go for a scan, and the scan shows mesenteric lymphadenopathy. So you need to think in the angle of infective causes. Let's say long-standing typhoid, long-standing salmonellosis, long-standing leptospirosis, and these kind of causes can be the ones which can present as mesenteric lymphadenitis. So try to rule out the infective causes. Go for blood culture, go for a stool culture, and try to find out if there is any particular infection. Now, once all those infective causes are ruled out and patient, let's say, is completely asymptomatic, for temporary, you can leave it that way. You can try to repeat the scan, let's say, after 6 months. Okay, and then you can see if there are any symptoms. During this course of time, if patient presents with weight loss, patient presents with constitutional symptoms, then go for a CT with contrast, and then you will be able to localize the cause.
Next question from Dr. Nitin. What are the differentials for spleen?
So differentials for spleen can include splenic abscess, it can include splenic rupture. Then sometimes patient may not present with abdominal pain, but patient may have splenomegaly. So that can include CML, it can include myelofibrosis, then it can include long-standing malaria. It can include, if the patient is from Far East, it can include Kala Azar, it could include tropical pulmonary eosinophilia. There are many, many causes. So it's important as to what the patient presents with. Most likely, unless it is stretching the wall or stretching the capsule of the spleen, it will not cause pain. Okay, so if it is causing pain, then most likely it could be a splenic abscess or a splenic rupture. If not, then they may present with other constitutional symptoms.
Right. So since there are a lot of questions, I'm taking some of the similar questions and addressing it together. So next is from Dr. Arun, treatment for pain in IBS.
Right. So most of the times patient presents with diffuse abdominal pain with no other cause. Patient may have a very stressful life. Patient is very anxious. Patient may have sometimes diarrhea, sometimes constipation. Just remember, look for the alarming signs like night pain, or patient is having bladder incontinence, patient is having blood in stool. These are all the alarming symptoms. If all these alarming symptoms are not there, you can go for treating it. How do you treat it? Direct it towards three things. One, are you treating the pain? Are you treating the diarrhea? Are you treating the constipation? If you're treating the pain, you can give antispasmodics like cyclopam. If you're treating the diarrhea, then you can give more like bulk medicines, and you can give probiotics, which can help. Then you can give for constipation, you can give laxatives. So these are all you direct the treatment as per the symptom. So in IBS is the only case where you direct it as per the symptom.
Another question from Dr. Patel is, if the serum creatinine is high, can we ask for IV contrast CT abdomen? And what are the newer radio contrast medium?
So the basic thing that we need to know is that nowadays, most of the contrasts that is available most of them are Reno safe. Okay, most of them are nephro safe. So you don't need to worry much. If the creatinine is high, then one easy solution and one way to prevent a contrast induced nephrotoxicity is give an IV saline before the procedure and after the procedure. Keep monitoring the renal function test for next 5 to 7 days, and then we can see how to proceed further. So most of them are Reno safe as of now, the newer generation ones. But unless the creatinine is very, very high, where there is early CKD, there's proteinuria and things like that, then only you need to be careful and avoid CT contrast.
Next is from Dr. Shrinath. If the vomiting and abdominal pain is due to the stoppage of steroids, how do we manage this case?
Simple, you only gave the answer. It is due to stoppage of steroid, so you will restart the steroid. So if it is due to acute adrenocortical insufficiency, you will start the steroid at a low dose. Let's say you give high injection hydrocort, and then gradually taper it and make it into Visalone and give it for tapering doses. Suppose, let's say patient is having some autoimmune condition, then there's no option. You have to continue steroid for a long period of
time. Next from Dr. Bhavesh, acute abdominal pain with eosinophilia.
Right. So that is something which is very important. So most of the times when we take a blood report, we always see eosinophils to be high, let's say 5%, 10%, 13%, 20%. And then we are confused. So we always think in the angle of allergies when it comes to eosinophilia. Okay. So most important thing is, apart from allergies, you need to rule out parasitic infections. Okay. So let's say strongyloidosis, or you can say, let's say schistosomiasis, or any kind of those kind of infections. So you have to rule out parasitic infections, go for a stool culture, stool routine, and apart from that, you need to categorize the patient into a category of hypereosinophilic syndrome. Okay, once you get hypereosinophilic syndrome, there are a few categories for it, where there is presence of end organ damage, where there's presence of absolute eosinophil count more than 1.5, and there are 2-3 more parameters. Then you categorize as per the symptoms. If you see gastrointestinal symptoms, most likely you should rule out eosinophilic gastroenteritis, eosinophilic proctocolitis, eosinophilic esophagitis, and all of these are diagnosed by endoscopy. You go for endoscopy, pick up some tissue, check the eosinophil cells in it, and then only you will be able to diagnose it. So this comes under the category of hypereosinophilic syndrome with gastrointestinal symptoms.
Next from Dr. Purohit, how to diagnose epigastric pain?
So just like I mentioned earlier, the differential diagnosis, let's say cholecystitis, pancreatitis, or any of those causes. So if you see all of those symptoms, then you can categorize it as per the nature of referral of pain, whether the pain is on the backside, patient is having fever or not, and things like that. So just like I mentioned earlier, it follows the same pattern.
Next from Dr. Datta, how to diagnose abdominal epilepsy or acute porphyria or vascular obstruction from sickle cell anemia when no localization for pain abdomen is found?
Yes, that is something which is important, that sometimes it's very difficult, that if there is no localization, then we need to think of other causes. So one thing you can do is that you check for the urine sample. If you have a strong suspicion of porphyria, where patient will have abdominal pain, not only abdominal pain, with photosensitivity or neurovisceral symptoms. If any of those kind of symptoms are there, Ask the patient to take the urine sample, place it in sunlight. If it turns dark, high chances of perfect. Okay, that is one. Now coming to sickle cell, you need to ask for family history. That is very, very important. Okay, apart from that, you also need to check for the complete blood count. Along with that, you can look for any previous history of stroke, any previous history of severe chest pain, looking for any crisis like vaso-occlusive crisis or sickle cell crisis, and then you can further diagnosis by HB electrophoresis.
So next is from Dr. Kostev. What are the common medications for fast to prevent acute abdominal pain?
So it depends upon the symptoms actually. If you're having a colicky pain, then you can go for mefenamic acid, you can go for tramadol. And if you're having more like an epigastric pain suspecting gastritis, you need to give proton pump inhibitors. You can give something like sucralfate, or you can give a mucane gel. Okay, and if you have something like a diverticulitis or an appendicitis, again, mefenamic acid, tramadol can help. If you have a neuropathic or a somatic pain, again, tramadol can help. So it depends upon the cause. If you have a very colitis pain, even cyclopam can help. So there are many medications available which you can try.
So sir, is it okay if I take the last two questions from our audience?
Sure.
Yeah. Next is from Dr. Prajapati. What are the symptoms of post-operative adhesions and how can it be treated?
So most important is that when you have a case of post-operative case, so you need to look for first thing guarding, if there is presence of guarding, if there is presence of nausea, and correlated with the surgeon, because you need to ask the surgeon how was the surgery. That is most important. Along with that, you check for the blood reports. Okay, so if let's say the complete blood count was normal pre-surgery, post-surgery the total count came to be 21,000. Serially monitor it with ESR and CRP for the next 2 to 3 days. If the counts are decreasing, then most probably the inflammation is subsiding. If the counts are not decreasing, then there is a possibility you can think for post-operative adhesions. Then of course you can go for CT scan and evaluate it further. For treating it, you need to cover the infective source. That most probably in the abdomen, it is anaerobic bacteria. So try to cover with antibiotics, which can help, like adding a metronidazole will definitely help.
So taking in the last question, and so we had multiple questions on this, differentiate rigidity from guarding.
Okay, so as I said earlier, just like what we follow the Carnot sign, you can actually ask the patient to flex the neck and you can see if the patient is having severe pain. Another thing is that when you have a guarding, you will feel more like a mass. Okay, so when you palpate the abdomen, you will feel more like a mass. And if you see more like a mass, then there is possibility that there will be guarding. Then another thing, if you really want to know the difference between rigidity and guarding, just ask the patient to make the abdominal muscles tight. If the muscles tightness is characteristic of a rigidity, presence of a mass, presence of an infective component helps favor guarding.
So with that, thank you so much for patiently taking in all our questions from our doctors. Thank you so much for this session. And with that, I would also like to mention that there's a lot of appreciation coming in from our doctors for this session. Thank you once again for doing this session and really hope to see you again on Medflix.
Thank you, Dr. Varsha. Thank you for this opportunity. Thank you very much.